So, wishing you a very happy new year to my fellow colleagues. And it's been a while since I uploaded my last video. It's already been 1 year. So, I've taken this time out to upload regular videos from now on because I heard a lot of support from my junior surgeons recently. So, yeah, starting this surprise series for you all, in which I'm going to show you some surprises during your routine phacoemulsification cases. So, starting this case off, I've injected blue dye. I have put an air bubble in the AC. From the beginning of the case, you can see something strange in this patient. What's strange is this patient is not an ordinary patient. This patient is somewhat jittery and has a lot of movements in his eyeball. So, coming to the most critical step in uncooperative patients like this, we are going to start our rexis. We are aiming for a big rexis because I feared something might go wrong in this patient who is on antidepressants right now. This is a psychiatric patient, and we have completed a 5.5 millimeters to 6 millimeters of rexis in this patient. We're going to implant a monofocal IOL under Ayushman Bharat scheme for free. Yes, we are operating this patient free of cost, and I have created a main port, and we are going to do a gentle hydrodissection. And oh my god, did you see what just happened? This was the first case of the day, and I was taken aback just like you with what just happened right now. So, as soon as I attempted my hydrodissection in this patient at 12 o'clock position, the patient got up. Yes, the patient literally got up during the surgery. So, let's take some time out to slow this down, and this is a good opportunity for you to learn the rexes as well. I have started a flap from the center of the anterior capsule to the periphery. I'm taking care to stay 2 mm behind the flap, and yes, I'm just noting the edge of the torn capsule. This is the best way to control your rexes. You should not aim to look at your needle but on the torn edge of the rexes. I'm using a combination of tearing and shearing forces, and if I feel the rexes is going to be smaller, I increase its size, and if I feel the rexes is going outwards, I pull it in the center of the torn edge so that its size can be controlled. So yes, this was a golden tip for you all beginner surgeons to go ahead, make a beautiful rexis. And yes, I have completed the rexis. Nevertheless, I've slowed down the video for you to notice what happened in slow-mo. I'll create a biplanar main port. I go up and then I go parallel to the iris so that it has a good valvular effect, and I don't need to do a lot of hydration at the end of the surgery. It also creates a very good AC fluidic mechanism during your surgery. So a good main port is a must for a good result for the patient. And I'll start doing gentle hydration in the superior area, and as soon as I attempt it, I first make it a point to take out the rexes, the torn rexes also, the anterior capsule. And as soon as I see the patient is already in a partial Bell's phenomena, and as soon as I put my rexes, here you go. The patient gets up and my needle goes through and through the fornix of the bag. This is my speculation that at this time I am speculating in the OT that the needle has gone through and through the fornix, the zonular bag complex, and into the vitreous. And as soon as I realized it in milliseconds of reflex action, I took the needle out of the bag and of the main port. Right now I have no clue what damage I have caused. It's an iatrogenic damage, and as soon as I see blood pulling in the anterior chamber, I am in for some surprise. I'm really worried at this point in time as to what to do and how to handle this case, how to complete this case, because I don't know, is the bag integrity okay or not. So I can see the blood, and my first attempt, my first saving technique is to arrest this bleeding. And we all know, to tamponade an uninvited bleed, you need to put a lot of visco in the anterior chamber. Create that pressure, create that tamponading effect of the visco has on bleeders, just like you do in SICS bleeds or in trabeculectomy bleeds. You put visco and stay there till the bleeding time of the patient. The bleeding time generally is 2 to 3 minutes. You put visco in the anterior chamber and wait for 2 to 3 minutes till the bleed goes away, till you cannot see more bleeding in the anterior chamber. So yes, I'm going to fill the anterior chamber with visco, wait for some minutes, grab hold of my senses and of reality of what just happened. We are encouraging the patient to look into the light. Yes, the patient is a psychiatric patient, but we cannot do anything. Let's speed this video up because yes, I've put some visco. We are waiting. We are just seeing the other damage caused. Is there anything else that I can do? And right now I'm frightened, I'm scared, I'm terrified as to whether to proceed ahead with phacoemulsification or convert this case to SICS for better safety of the patient. I also thought to inject some lignocaine, a peribulbar block for this patient, but this patient is a psychiatric patient and I could not risk any more uncompliance from this patient. See, the patient is still jittery as I am giving him verbal feedback as to what he has done and what he can expect out of this eye now. But still, we're going to move ahead on a sword's edge, and you're going to bury our tip in the belly of the nucleus and start chopping the nucleus with a fear in our heart that the nucleus can drop in vitreous at any given point in time. I want to give block, as you can see my lignocaine needle, and yes, I think I will move ahead with the medial block for this patient. At least 5 mm of block is needed for this patient to make the procedure safe. And yes, I have given some medial block to the patient, and we'll go ahead with the chops now. I'm trying to rotate the nucleus in the bag so that I can see any zonular laxity or any zonular dehiscence that I might have caused. Right now, still, I don't have a lot of clue. So I go ahead with mild hydrodissection procedure so that I can free the nucleus from the bag. Things look good right now. If I tell you, the zonules seem attached to me. I have not caused a lot of damage. In these cases where there is recurrent bleeding, ADR can also be helpful for you guys, because ADR is a vasoconstrictor by nature and you can put ADR in the anterior chamber and wait for some time. If you cause some iris damage in those hypermetrope patients where the AC depth is low, you catch hold of iris with your phaco or any of your instruments and the patient starts to bleed in AC, you can put adrenaline for some time and wait. You can use visco, of course, and you can use ADR as well. So things look pretty good. I'll start my chopping now. Just getting ready, and we are waiting for a couple of minutes for the block to take its action. The patient has calmed down a little bit. My OT assistant continuously gives him positive feedback and rewards for his good behavior. It's just a tug of war between reward and punishment. Punishment never works in patients like these. in any of your patients, of course. Yeah. And yes, we are going ahead with a modified direct chop. I use horizontal and vertical both kinds of forces to just crack these hard endonucleus pieces. And yes, I'm going to make 4 or 5 quadrants and then go straight away to quadrant removal. Just take care to separate the posterior pole out without causing minimal stress on the bag, of course. And till now, the bag seems to be holding back really well, but I am ready to handle any eventuality that comes to me if the bag opens up or the I encounter zonular dehiscence. I have a CTR ready on the trolley. So just a quick review of the post-op visits of this patient. We gave him thorough checkups with indentation fundoscopy, with the gonioscopy as well. We continuously tracked his IOP readings for angle recession or any of that stuff that might have caused damage to ciliary processes, ciliary body, or even ora serrata of the retina. We followed him up for around 6 months for any impending retinal detachments there might be. But yes, the patient fared really well. So, yes, the second heminucleus is gone, and just like that, the bag has held really well in the whole phacoemulsification procedure. You can see tiny amounts of bleed in the subincisional area in the anterior chamber, but that is just a blood clot and not a fresh bleed. So I'll be really gentle with my I&A. I&A poses greater risks for patients like these because you can easily detach the bag in the area where there are weaker zonules, and this was the area. I'm just rushing through the video. I have sped this video up for you all to notice key points only. You can see a solitary vitreous floater in this patient, I guess. So just putting a monofocal acrylic IOL in the bag. And let's call it a day. I hope you like my videos. This was a strange surprise case that you all can encounter as you get more and more experienced in these patients. In your early days, I would recommend to give a peribulbar block in patients like them. But even if you give block, you should be ready for any eventuality that comes through, catches you off guard. The neck movements, patient getting up, patient sneezing, patient coughing, patient touching their noses, their faces with their hands. Anything can take place, and you should be ready for everything. That's all from my side. I hope you like my videos. Kindly like, share, and subscribe with your fellow residents. It takes a lot of good effort to make these videos. Thank you. Signing off.